Welcome everybody to the fourth quarter CHPC, fourth quarter of fiscal year 2016, and we're kicking off the summer, and I'm very pleased it warmed up a bit. So with that, let's go straight into announcing this topic. It's domestic violence, and we'll do a little bit more of an introduction as we move down the road, but this is today's topic is domestic violence. And if we can go to the next slide. And we want to stay on time, so I'll quickly blow through the regular slides that we see on a regular basis. And this is our agenda, and we'll go straight into General Lanza's opening remarks and welcoming folks. Do you want me to kill some time while you choose? So I'll do some logistics. So we have the restrooms off to the side.
Okay.
We have exits in the back and the front. Also, let's talk about the mics. So those at the front table, you have mics. Let me remind you that you have to click it off and give it a few seconds. Otherwise, it'll pick up your sidebar that you may not want picked up on the mics. We are being audio videotaped, so we make CDs to share those with the folks that cannot attend. Also, reminding folks, we have a mandatory participation. We're required to have our members participate in the CHPC, so we have sign-in sheets to track. So please sign in before you leave if you haven't. And also, if you're representing someone, please sign in so we can make sure that we get your accountability. There you go, sir.
Okay, well, good afternoon, everybody, and thanks for everybody coming here, all our teammates. I just want to reiterate the work that's being done on this installation collectively to build readiness. And part of the CHPC here is not really to just address what the problem is, but get after solving the problem. So when we get into emergent case management and some of the outcomes that have been done from the CHPC, it's helping whether you're an airman or a soldier or a civilian. These are designed to enhance the readiness on the installation. So today's topic on domestic violence is not so much just on domestic violence, but the precursors of the issues that lead to domestic violence. And if perhaps we can get after prevention of those issues that are the precursor to domestic violence, then we get after solving issues that deal with family breakups, issues with children, and we're going to get into some significant issues here of what causes this. Plus, I think Tricia is going to show us some of the things in terms of the severity of what we're getting after here. So as you go through the slides today, again, we're after what we can do to actually solve problems on the installation. We are breaking down stovepipes on the installation, so it's not just emergent case management, but what we've seen here by the entire team here is more crosstalk, more flattening of the organizations on the installation to get after what commanders need done prior to incidents occurring. So again, my thanks to the entire team here. I look for solutions to this particular problem set today, and more importantly, where we're after with prevention, vice intervention. Some of the same discussions we had at the SARB this morning. So with that, Trish, my thanks to you and Sheena and to the team, and I'll turn it over to you.
Okay. Thank you, sir. I want to do a quick check for those that were handing out the red and blue tickets. Were they all given away? Great, okay. We're going to be using those in our exercise, so please hold on to those. So my next piece, sir, to continue to have you come up here in just a moment, we would like to do a recognition. The last several CHPCs, we recognized soldiers that were able to intervene. It was part of their duty. They stood up and intervened. And you had mentioned that we do have other resiliency champions in the community, not just our soldiers, but civilians, family members. So we wanted to also open up that recognition and recognize family members. So I'm going to turn the mic over to Joint Base Headquarters Command Sergeant Major Mo Ryan.
Sir, gentlemen, ladies and gentlemen, it's a quick privilege of mine to introduce and offer for congratulations Mrs. Megan O'Day. She works with our Exceptional Family Member Program. She's been with us since January of 2015, and her impact has been immediate. Quality of care, quality of concern, a genuine, engaged leader that represents us. She represents what taking care of family is all about. Now, I could sit here and kind of come up with some grandiose or generic stuff, but I think what I got earlier was a testament, an ICE comment from one of the families that she had helped directly, and I would just like to share that as an example of one of the many impacts that she's had on soldiers and families. Mrs. O'Day has been exceptionally helpful, has been an exceptionally helpful individual with providing knowledge about EFMP, program, paperwork, and helpful hints to be able to fully facilitate the care of our son. She has gone out of her way to the extent that even after we've PCS'd in October of 15 to Benning, she's encouraged us. She has an overwhelming wealth of knowledge and should be a first choice when looking for anyone who can help navigate such a deep and murky subject such as EFMP. Mrs. O'Day has been able to provide my family with the information and knowledge necessary to navigate the system with great success. She has a large knowledge base and allowed my family to not become discouraged. Her attempts to help my family have been welcomed, and she is a star shining through the clouds of the EFMP program, and we greatly appreciate her help. So, sir, I'd like to introduce to the audience and to you Mrs. Megan O'Day.
Get after you guys. Can you hear me without the mic? Okay. You can't hear me? Okay. So one of the things we talked about with this meeting here is what we're doing on the installation to get after not just solving problems, but the ability to coordinate, communicate, to affect positive outcomes for soldiers and families. And I wanted to make sure that not only do we recognize certain individuals, but we make it public, because the entire installation working together here is extremely important, and this kind of recognition is what excites us, and what brings passion to this, and what makes us better here to solve problems for our service members and their families. So Megan, congratulations, thanks for your leadership, and thanks for all you do to support us.
Thank you, and I'd like to add, Mrs. O'Day, you really do show that continuity of care that we all talk about, and that warm handoff with the family that transitioned to another installation. And we always talk about the warm handoff that we want to send our families when they go to other installations. So moving on to our regular CHPC business, I won't read the meeting objectives to you. For those that are new, you'll notice that they are action words. This is a decision-making forum here at the CHPC. Next. And our purpose comes straight out of our charter. We are a comprehensive and a holistic body, a council that sets the CHPC priorities and also supports the implementation of preventive measures. And prevention is definitely the key word at today's meeting and the rest of them as we continue to meet. So again, for those that are new, this may look new. It's very busy, but it does show what our CHPC structure looks like. And the blue circle at the very top is our Community Health Promotion Council. As today, everything below that is our foundation. And it's not in a hierarchy of importance. It's how communication flows bilaterally up and down across the board. We have issues that are raised up at the foundation all the way down to the unit health of the force or wellness councils, you might hear them. And we have a representation of what those working groups look like. Sheena, if you can click on.
Leo, one thing I would offer, if you want to be tied into the HRAC with General Fuller, it might be an opportunity for your airmen and for the wing. So right now, you're technically not tied in, but I think the HRAC is what tees up these issues that then we can look at solutions in the CHPC. So I offer you guys, you and Chief, the opportunity, if you want to tie into the HRAC with the Air Force, that might be helpful down the road.
Yes, sir.
And plus, it brings a perspective that we don't have as well in terms of what you guys can contribute.
Sir.
We'll make sure that you get the invite to the HRAC. And the HRAC is the second blue bubble in this chart, and that's our executive board. So going back to the working groups, as I say, is the three legs of the stool that represent Joint Base Headquarters, First Corps, and Madigan Army Medical Center, the Health Readiness Platform. And what those working groups look like. See, Sheena, there you go. You gave me the clicker. Thank you. Now, don't expect that you'll be able to see that, but that is a splice of what our working groups look like. So when we expand it, there are many working groups, and these are only the strategic level working groups. There are many working groups, and Sir General Stammer had asked me about being able to identify a lot of those working groups. And this is just an example of some of the strategic level that we have: the Air Force, the CABE, and the IDS reflected, all the different ones at the Joint Base Headquarters and the First Corps, going all the way down to the brigade health promotion
I
teams.
do have one tasker for the team here. Is I'm looking for your feedback on where we can continue to effectively communicate and flatten the organization. So I've gotten some feedback from Alicia and Dr. Darnell, but where can we continue to facilitate how we are more expedient in how we action things on the installation, how we crosstalk, and how we have more fusion to challenges that impact other organizations? So how do we tie medical perhaps with ASAP and others? So I'm looking for your feedback on innovations where we continue to flatten the organization and facilitate communication and integration. So that would be helpful down the road. Thanks.
So this next chart, we go into our do-outs, and I'm not going to go over all of the do-outs. We look at these at the executive board and the HRAC. That's our monitoring and tracking board. But I want to highlight the themes we have in the past that have already gone to green: actions around medical readiness decision points, identifying suicide risk, building suicide risk tools, looking at assessment, also looking at integrating units into the CHPC and our partners into the CHPCs better, MRTs, and then I'll end on what's still in amber. It's because it's still in progress, and this is the development of a health of force communication plan, so we can have a better integrated, comprehensive installation health of the force communication plan. And the next one is, again, following up on a few more. What's still in amber is going back to that warm handoff, sir, that we talked about at the last CHPC, the sponsorship and transition. And there are two pieces to that right now that we're tracking, and those things that are going on for the Soldier for Life program, and getting people that are transferring in and transitioning out. And then also the medical readiness initiative that's going on. So this is still in progress, and we'll continue to track it. And I already mentioned the CHPC integration, that we are tracking and ensuring that we integrate CHPC efforts all the way down to the unit levels. And then I want to highlight one specific project. Is exactly 1 year ago, the Health of the Force white paper with the task force recommendation was published, and this was a request from General Lanza looking at preventable deaths and risk in the community. We received a draft op order that would have been very prescriptive, so we turned around as an installation and developed a task force to look at what our own risk and how to mitigate them were. And if we can go to the next slide. What we're tracking right now, this is still being developed. So all of those Health of the Force paper recommendations and findings, we're already collecting all of the outputs. We are seeing changes that have been made. And now next we're going to be looking at outcomes. And we're really trying to move from measures of performance to measures of effectiveness. So we'll continue to use this tool to update the community on what our findings are and what our outcomes are. And so with that, I'm going to introduce the topic of domestic violence, and just wanted to kind of introduce how how this was brought up for this particular CHPC. Our last CHPC 3 months ago was on family resiliency and family preparedness, and domestic violence came up as a part of that, and really had a lot of questions about what are we seeing out there and what are we doing. We also, using that organizational chart that we saw in use, was a working group from one of the units brought up domestic violence, and it was elevated up through that system that I talked about. That's a good example of how the system works. So we looked at the domestic violence piece through the family resiliency and also through soldier readiness lens. And I'm going to talk a little bit, I'm going to turn it over to talk in a minute to talk over about that, how it came up at the unit piece and that process. But I wanted to get some clarifying language when we talk about domestic violence. There are two lengthy descriptions of what domestic violence is. And we have both the Department of Defense, what FAP uses, and also the Office of Justice, and this is the legal. So you'll see one more in courts and one more within the program itself. So these are the definitions for you to refer to. And then next we have the definitions when we talk about domestic violence, the types, physical abuse, emotional abuse, sexual abuse, and neglect. So again, as we move forward and talk about domestic violence, these are the things that we are talking about. And I'm going to turn it over to Lieutenant Colonel Chris May from 593rd ESC, who runs their Wellness Council and has great communications with the wellness councils down at the unit and brigade level to be able to elevate issues. And turn it over. Oh, that's a good, another reason, sorry, Lieutenant Colonel May. Another reason we're talking about domestic violence. Some of you might recognize this. This is from the CHPC Effectiveness Survey. So we have over 60 CHPC members as part of our membership. And each member was asked to participate in the CHPC Effectiveness Survey. And what we heard from our members, again, our members, we asked them if to rate their level of agreement on whether the CHPC efforts are positively impacting our priority areas. So our strategic plan has 5 priority areas, and that is behavioral health, domestic violence, to include child abuse, substance abuse, physical fitness, and financial health. And why I underline domestic violence, what we found is it had the lowest agree score, and it had the highest I don't know scores, which tells us that we need to do a better job of promoting what is happening and promoting our outcomes and promoting the work that is going on in the installation so that our members do know what's going on. So without further delay, I'll go ahead and introduce Lieutenant Colonel Chris May.
Hey, sir, before Chris starts, yeah, I think he's going to kind of lay out how we have integrated with the Corps and the garrison and broken down some of those stovefights that you were talking about, and then in the case of this domestic violence, how the issue was elevated through that process.
What'll be helpful today, are there some sub-tenets of domestic violence that we need to focus on that are causing domestic violence? So I think as we had the pre-brief yesterday, I think you'll find there's some areas that cause domestic violence that we may want to focus on across the installation. I think you'll see that come out in the update today. Okay, Chris.
All right, so I think I'm up here just because Trish didn't want to do all the talking, so she wanted to put me on the spot. But really, we've already covered a lot of what I was going to talk about. A big one being the stovepipes, and the second one being how we're integrated. ARD was here a couple weeks ago, and they asked, what do we do different here at Fort Lewis or JBLM? And I think that's exactly it. It's just the civilians and everyone working here on JBLM have so much going on and so many good programs. It's just hard to get down to the green crew level, or at least so commanders know what's available. But over at 593rd, the way we kind of do things is every time something else comes up, I integrated our Clancy and Dr. Darnell a long time ago into our wellness council so we can get the risk reduction piece, and so we can keep a good idea of what's going on and the trends and stuff. And so happened in March, domestic violence we had a big spike, and General Haley said, hey, what's going on? And I look back in September of 15, we had another spike, and it sort of went back to, we could have tied it to some redeployments, but we could have tied it to some other things. And so there's some great reintegration training that goes on over at FAP and so on. But wanted to dig a little bit deeper, and we did a great job looking into suicides. And with the 14 suicide I think that we looked into in the last 3 years, it kind of had some common themes. And I wanted to do the same thing with domestic violence. So I was going to do a deep dive into domestic violence. We know financial issues. We know there's several issues. But, I think back to my personal, I've been married 23 years. And I think my rockiest time with the spouse was not during 4 deployments or 2 unrestricted tours when I come back. It was when I was company commander. And never home, never that. And my wife didn't work. And it was kind of how she didn't have a social outlet. She's home with 2 kids, and I'd come home late when she wanted some plans, and just the tension was always there. So I wanted to do that deep dive into domestic violence to see, hey, what are these indicators other than the big ones that, maybe we can do some preventive training. So what I found out, having gone over to FAP, and then I did find out that there's 2 separate FAP has two separate entities. One, the Garrison side, which does the prevention, and then the Madigan does the clinical side. I didn't know that, so that's my bad, but I find out lots of things when I dig into this stuff. But really, the FAP side has a preventive training, and they can tailor it to anything really that the commanders have. So, and there's also lots of free programs that the commanders can have. And then on the medical side, where I wanted to get my information, it would just, I mean, I don't think a Harvard study group could get after the amount of data. So then we start, so as I sit down and we bring that together, we brought these entities into our wellness council to kind of, to get after that stovepipe. So, you know, and as I found out, there's several initiatives going on the Madigan side that you may have seen in the Senior Medical Council. And then also, I found out that maybe our training wasn't up to speed from the preventive side. So I really got a handle on what we need to get after as far as making sure we do the required training and then tailor it for when these certain things happen, and then bring those initiatives down to the unit so we can have a say. So really it's that those stovepipes that I found just in the last 4 months with domestic violence and family advocacy, we were able to bring down to the unit and then bring it together. So, I mean, my hat's off to all the civilians in here that are working that. And I really, if you don't have them coming down to your wellness council or even down to the battalion level, I mean, thank goodness to our Clancia and everything to help us kind of see what we see. And then on the other side is we get to really say what we need changes with. So, I mean, I think we just do a great job on the installation as a whole, and especially with what we're doing. So that's kind of how we got elevated. And then elevated up into, I think, with General Warrow, the Corps Chief of Staff, through the fusion cell. So how those work groups kind of keep coming up. So any questions on that?
Let me make one comment on this before we open it up for questions. For the CSF2 program, for the commanders in here, we're about 100% on MRTs in the Corps, across the installation. We're at 100% of MRTs trained. The question I would ask commanders is, are your MRTs being trained to facilitate their readiness, or are they able to train and teach others to build resiliency? And in some cases, I'd ask you, who are you sending to the course for MRTs, and can they take what they've learned in the program and then extrapolate that across your formation, or is it just helping them individually on their own resiliency? And I think in some cases, we'll have to see how well we're doing, but performance-wise, we're doing very well with MRTs, but how well is the program affecting building readiness and enhancing resiliency in your formations, and are the MRTs really doing what they're designed to do, which is impact others in the formation? And that means, are we picking the right people to do that? So I don't know that for sure. I have an inkling that it may be a mixed bag in terms of how well the MRTs are really affecting readiness across the formation, not just their individual readiness and resiliency.
Yes, sir, we're tracking that. We'll capture it as a do-out so we can look at that a little bit further. Thank you, Lieutenant Colonel May. And no, I did not ask you to come up here, so I have a different voice up here. You definitely, your process that you have has been very, very helpful in getting that integration piece. We've spent up here the last about 10 minutes talking about process. So I'd like to move us on to talking about the domestic violence in the landscape and what we're doing prevention and to support commanders. And to kick that off, we're going to be doing a quick, brief exercise. And let me introduce. We are going to start with a fictitious domestic violence case. So we have two volunteers who will be playing the married couple. So this is not based on anything to do with them or real life. So I will go ahead and read the case to you. So I'm going to ask the role of Staff Sergeant Annie Jones and Sergeant John Jones, or JJ as he likes to be called, to come on up. So what we have is a married couple, active duty couple with no children, who are assigned to different units. They live in military housing, and a few months back, Sergeant JJ Jones and his spouse engaged in a verbal altercation. This is a very common case that you might see. And it did turn physical when Staff Sergeant Annie Jones ended up punching her husband, Sergeant J.J. Jones, in the face, and then grabbed Staff Sergeant Jones by the forearms and slammed her into the floor. Sounds very violent. This is a very typical case. Staff Sergeant Arnie Jones continued to fight her husband, scratching his face and kicking him in the groin. Staff Sergeant J.J. Jones then punched his spouse in the mouth and placed her in a chokehold. Again, they live on post. The neighbors on post heard the altercation and called MPs. I know it's a little bit graphic. This is, again, like I said, a typical case. Both soldiers had injuries and both were drinking, again, very common, when they were arrested. And I'm going to go ahead and turn it over to Staff Sergeant Annie Jones.
Good afternoon. Today I want to recognize all the agencies that assisted me in my altercation. So all the personnel with red cards, when I call you out, please stand and remain standing until we are both complete. My first sergeant and commander who picked me up from jail.
So whoever has the red card that says First Sergeant and the red card that says Commander, could you please stand? For those that put them in your pocket, we'll give you a second.
The JAG personnel who provided me legal guidance. The military police who responded to the 911 call. The military police who investigated the incident. The CID who responded after the assault. The victim advocate who responded to and supported me in the hospital. The physician who treated my injuries. The command-directed escort for my multiple visits to behavioral health. The command-directed escort who picked me up and helped me pick up my belongings from my residence. The FAP assistant social worker. The behavioral health provider. The ASAP provider. The Case Review Committee. The FAP Treatment Social Worker. And my 4 battle buddies who assisted me. And if there's anyone left with the red card that you were not called, please stand now.
I also want to recognize the individuals who are involved in my case. If you are holding a blue card, please take the time to stand up. Many other people standing provided the same service to me as they did my wife. For a few of them standing are the same people, but many had different responsibilities. I had my own unit response and unit mobilize.
Thank you. I'd like to take a second, if you could look around the room. When we talk about one case, the impact on a commander, staff, and resources on an installation for one case. And what I've been told is if there were children involved in this case, this number that we see standing would double. So again, when we talk about the impact that a domestic violence case has on the command and the installation, it's pretty eye-opening to see this. And I want to thank those that are standing. You can go ahead and sit down and taking part of this exercise. And I want to thank those that actually fill the role that we called out and support our soldiers and our family members on the installation for the work after a domestic violence case. And it goes to emphasize how much time for prevention versus this kind of response when we have an incident.
Before we move forward, can I ask you, the guys up there and the leaders behind me here, what are some of the major causes we're seeing on domestic violence and/or child abuse or neglect? What are you finding are the precursors?
Sir, and I can ask some of the FAP
That would
folks
be
to come
helpful.
up also.
That'd be-
So if the people that are presenting, Susan Domini, Robin, Kelly, and Bob, if you're here, if you can go ahead and come up front just so that you can field any questions. And I'll ask our volunteers also if they can sit down. They're squirming. Thank you so much for the participation. Again, it's an eye-opener of an exercise. So again, in repeating the question, we're going to be talking about what are we seeing out in your commands, in your units, in your formations that you're seeing around domestic violence, and what can we do to prevent it? Sir, if we can get you to turn on the mic also, we can pick it up.
I'm just trying to get my arms around some of the precursors here for the commanders to have a discussion on. So, okay.
Well, with that, I think that we can, kind of start the conversation about what domestic violence looks like and have some of the SMEs talk about that. And definitely, while the SMEs are up here, you can ask questions. That's why we brought them forward. And I want to introduce, well, before I go, I have an example when we talk about the impact of domestic violence. I showed it at installation level. This is one slice example at the medical level. So this is from the CDC. It's an older study, but they still utilize it to show the response when domestic violence has an injury. They looked at 1,400 cases, and over 40% had an injury. And then it shows from that 40%, the kind of response that the medical community had to do. We had dental care, we had medical care, ambulance care, physician care, hospital care, physical therapy. And within the hospital care, we had the emergency department, outpatient care, and victim and admitted to a hospital overnight, so we had hospitalization. So just even one slice, when we break it up to hospital care, we can see that it has an impact. And I'm going to now turn this over to Ms. Robin Kelly from Family Advocacy Program, the clinical side over at Madigan Army Medical Center, that can talk about some of the data and some of the things that we're seeing in domestic violence and child abuse. Either way, we have a microphone up here.
Yes? Do you want me over there or over here?
Wherever you would like to
Okay.
stand, Robin.
I'm not a data person. I don't love numbers, but we wanted to give you a little bit of visual of what we're looking at. And this is JBLM DV trends for new cases. And you can see that statistically, it's not real significant. We kind of hold steady. We do see peaks often at certain times of the year. We usually see them at the end of the school year. We suddenly get an influx of reports coming from the schools because the summer is coming and the school providers have noticed that a child maybe has been at risk, maybe they've been feeding them, maybe the clothing wasn't so good, hygiene, and now summer's coming and there's a little bit of a panic of, oh my God, who's going to make sure these kids are okay during the summer? So it's real typical that we see sort of an influx. The end of June into July, our numbers typically go up. I think this will pretty much show you that.
We can look at the trends if you
Yes,
want to.
thank you. I jumped ahead, always. So you can see the trends, but again, we hold pretty steady.
Yeah, that's not statistically significant.
Not
We're
at
talking
all.
about raw numbers up at the top. And this is fiscal year 15.
Again, not terribly shocking. We sort of hold pretty steady to certain times of the year. New cases in 16.
And this goes back to that patterns when you talk about predictive analytics, the patterns that you talked about seeing spikes in the spring and in the summer that you were mentioning.
And we're going to see summer month. We get a lot of reports during the summer. Our child neglect cases often will go up at that time. Maybe kids playing outside, maybe kids not being supervised as closely as they could be. So we're going to see kind of an upsurge at that time.
And we put a question mark for the rest of the year. This is where the data stopped, but really, how do we get ahead of the game as we move forward to curb the spikes that we're expecting to come up in the summer?
These are your definitions of different kind of child abuse. Any child sexual abuse is considered severe, so it's off the board. Also, the spouse and partner maltreatment. So we just wanted to give you an idea of what it entails.
So as we move forward and look at some severity slides that track severe cases, things that are coded as severe, you have mild, moderate, and severe.
Right.
These are the definitions for severe.
Hey, I got a couple questions, if you don't mind.
Yes, sir.
It goes back to your JBLM DV trends. And again, I'm brand new.
Yes, sir.
But if I'm brand new and I can't understand this and we're not doing what we should be doing for all these people and their troopers. I'm looking at the one where it says DV data, looking at trends, patterns, and possible predictions. I didn't get any of it. I got a bunch of bar graphs and a bunch of numbers, but I didn't get the why, what changed, what in the environment happened to make these numbers do this. And I got, okay, spring and summer, I got that.
We
But I
get
can't turn
springs-
spring and summer off. But I got to be able to do something else, because spring and summer is going to come every year.
Absolutely.
So I got to have
Absolutely.
something else a little more tangible. So we need, at least I need to go past this chart 5 or 6 levels to understand what are the trends. Spring can't be it.
Oh, no, not just spring. But we do see an upsurge around holidays, alcohol-affected holidays.
Why?
Our soldiers are drinking. Our younger spouses and soldiers are
I'm
drinking.
going to go 5 whys every time,
Okay.
because by the time you get to the 5th why, we might find out why this is more meaningful. We won't bring this out, but this will be a pattern that I'll intend to.
And
to
I'm
go
good
on.
with that, sir.
And then
After
I'll
we-
go forward to this one. If you could go forward to your blue chart,
Yes.
those are all felons. We need something to the left of that. Those people ought to be in jail. You're talking about trying to rehabilitate felons here. Those guys are all going to go to jail on that chart.
And
What
not-
about to the left of that so we can actually keep a trooper?
And I guess, sir, I'm going to respectfully disagree.
Okay.
Not felons,
No,
poor
that's good.
choices. I'm going to go back to, and these
Child sexual maltreatment.
automatic.
Any incident.
Automatic severe.
I'm going to vote for that guy to go to jail, but that's just me.
Absolutely.
Child neglect, okay, he might not be a felon,
Nope.
but that's criminal behavior, right?
FAP is not a criminal entity, and I know that's hard to.
I want to
We're not
separate
criminal.
fat from the crime.
And I understand that, sir, but that's our problem, in my opinion, on JBLM, is we're taking the family advocacy program and we're making it a criminal entity. We're saying we're law enforcement, we're going to assess you, instead of saying I'm going to assess you
Okay, I got
for
that.
treatment, previously, historically, FAP has been, you're an abuser. You're going in the central registry because you slapped your wife, you slapped your kid, and you left a mark.
So, ma'am, is your concern that you're not getting people earlier in the process, that you're getting them?
Absolutely.
So your concern for the commanders here is you feel in FAP that you're getting soldiers after the fact?
Absolutely.
As opposed to leveraging FAP prior? So are we identifying the right people earlier on so it doesn't become an issue?
Absolutely.
But that's not what you're saying is happening?
No. I want to get them before we get to where they're breaking bones and busting heads. This is the end game, and it's not really what we here at FAP are doing. And we, in the last 6 to 9 months, have turned this program into a program that says, you know what, First Sergeant, you got a problem, Command Sergeant Major, you have a problem. Your child, you have 3 cases where we got pushing, shoving, breaking cell phones, we call them young, dumb, and silly stuff. Nobody's getting hurt yet, but you know that you've got a problem in your command because you're getting called. The wife's calling you, and or sometimes they're getting picked up by law enforcement and you get to go to the Nisqually jail and pick them up. So rather than reaching that point, I hate it when a commander comes in and says, yeah, we had those incidents in April, and I thought we could handle it as the command. Don't do it.
So would you advocate then making a commander's critical information requirement, making it a little less stringent, like a domestic argument?
Absolutely.
Where the MPs are called, make it a CCIR, not so the chain of command at the CG level can go down there and hammer that guy, but so you can start identifying trends when they're arguing versus snapping each other's backs.
Absolutely.
Sir, let me interject here. We've actually, over the last 6 to 9 months, figured out a way to carve resources out to make that program available to all commanders on the installation. So rather than the traditional FAP relationship, which is once they cross the line, now they go to FAP,
Right.
which means they've already had the incident, we are actually making these folks available not just as prevention experts, but as treatment experts to get the treatment before the incident, to literally get left of the slap. And that way we stop them from ever having to cross the line and be considered to have some sort of legal problem or felony or conviction or anything else. So exactly what you're talking about is what our folks have been doing. And I'm willing to put more money against that. It's other money that I got to come up with, but to squeeze the orange to get the orange juice, I'll do that if we have enough interest to get people there. So you're absolutely right. This doesn't need to get to the CG level. It certainly doesn't even need to get to the brigade commander level. Your company commanders and first sergeants across the installation want to take advantage of this program. Absolutely. And if I need to put more resources against it, I will.
So increasing the demand signal, Mike, on you from our teams here, you'll put resources towards that if we increase that demand signal earlier on in the process as we identify issues.
Yes, sir, because Robin and her team is more than happy to make sure that never happens. That's why they went into this business. So if we have the demand, I'll keep hiring folks to put against that requirement.
And sir, when we get further in the slides, that's why I hate graphs and numbers. They don't tell you anything, and they aggravate the hell out of everybody. I get that.
So, Robin, can I just interject? And we'll go through, and these are really great questions that we do want to get to those answers, those things that you're asking.
But you want us to go through the
we wanted
slides.
to look at the rearview mirror a bit because people had been shown slides and got the sense that domestic violence was getting worse. So we wanted to take a look at it so that we can move beyond just the numbers and talk about prevention. So I'll quickly.
Absolutely. Absolutely. We're getting there. Yes, sir. We're getting there.
So a good question here is if you look at that spike of 25 new cases in March of 16, how many of them went over to the FAP or a medical treatment facility and got counseling prior to the event? And I don't think we know the answer, but
Not a
that's
lot.
what we need to know.
Sir, every time someone comes to FAP, we do a background search and we look. So most of them not. Most of them are not subsequent cases.
But that would be helpful. That assessment, though,
Incredibly helpful.
is helpful to command. Go ahead, Kirk.
Sir, I need to throw this out. There was a captain count in my office about a week ago. This young officer came in and he said, I have a lot of folks and they're having troubles, and he started clicking them off. What are you going to do to help them? What are you going to do to help them? If we could get more young officers, I hope he works for one of you in this room, Captain Counts. That's what we need. And by the time he was done, we heard about the 3 that are currently engaged, and then we heard about a few more that he wants to know if we would handhold. Absolutely, send them over, get them in.
So I would tell you that we need to test the theory that we can get ahead of this by identifying soldiers that are having these kind of internal family issues beforehand, and that counseling and therapy and what have you will prevent one of these events from happening. So maybe a case study is to drill into that 25 in March of 16 and get into the details of who they were and what happened and see if there were any indicators that would have told the chain of command that something bad is about to happen. And if the answer to that is no, there weren't, then the theory doesn't hold water.
Or it may not be you. It may be someone else that they saw on the installation that triggered perhaps they should go to family advocacy.
And we search through the medical system.
Okay.
Or the MP system. I have the MPs waving back there. Major Vento, Lieutenant Colonel Vento, yes ma'am, sorry, sends us tons of reports.
And I'd like to add, when we saw those people stand up that showed in response to a domestic violence, you could say there's that many people that are involved beforehand that know something.
They know it.
And I'm going to forsake, kind of move us through very quickly for the data, because we didn't want to spend too much on the data other than we know we need to do a deep dive. We know we need to look at some of the co-founders, some of the core risk. And we talked about this at the pre-briefing. A lot of the risks that were identified for the LSRAT, the Leadership Suicide Risk Assessment Tool, are also some of the same risks that you'll find for domestic violence. Financial distress, substance abuse, occupational issues.
Relationship issues, family of origin issues, mental health.
This went over the child maltreatment by severity, looking at a spike in 14, leveling off for 15. Spouse maltreatment, we end up in the same place at the end of each quarter. We don't have 2016 data. But this is what we also want to look at. This is the beginning of when we ask, who are these folks when we do targeted prevention before we have to do a response. We pulled together some numbers, the table on the left, looking at population data, what the population is made up of that rank, and then the proportion of the cases. So we look at, for E1 to E4, even though they make up 45% of the population in 2015, they made up almost 70% of the IP abuse cases.
They're young, newly married, new to the Army, new to Washington, away from their families, young children, multiple young children. They're not a surprise. The E5 to E6, 38%, they're the parents of the teenagers. Any surprises there? Those of you that have teenagers that are individualizing and letting you know that you're not in charge of them anymore. Pushing, shoving, slapping, a lot of reports by teenagers at school.
We didn't have the population, and this is, I'd like to see a small group or a task force be able to pull the numbers by population when we look at by age and be able to do the same comparison. But we just put the raw percentages numbers that we had. And then to answer your question, we were going to go into prevention, but I wanted to see if Robin had any more comments. Are there any more questions for Robin? She's going to be presenting on some of those FAP changes that Colonel Place talked about to get left of the boom, to get to the prevention side. FAP has made a number of changes.
And sir, there's really concrete information on those. They're there.
So
we got a plan.
Do all these numbers represent severe FAP cases?
No.
By that definition? So these are all kinds rolled
Yes, sir.
up. So how do we know, where's the threshold? Is this, yelling or now we're into
We have to have an
physical?
act and an impact.
So something physical had to happen.
Not necessarily. It can also be calling your child horrific names and the child started cutting on themselves or vomited. There's severity levels even under verbal and emotional.
And I pulled back up the slide on slide 27, has those definitions again for severe.
And the
But we're
problem we
saying
have
that-
with this, sorry,
We're
sir.
saying all these new cases don't meet the criteria for a severe.
No.
So,
No.
yeah. I'm not really sure what.
Most are moderate.
Okay.
Sit down.
But sir, I'll tell you, having read these for the last year, and they come in batches, weekly batches, 75 to 100 pages. And what we're calling moderate, I think would probably scare a lot of people in this room. So moderate abuse, we got in a physical altercation, threw somebody's head to the ground and beat their head on the ground. Okay, that's moderate abuse. So got to be careful here. I understand that we don't want to get too far into, jumping over mouse turds for somebody that yelled at each other and somebody had their feelings hurt. But that's not what most of this is. And I think we can, by regulation, share that with you if you want to take a look at through some of these packets. But these aren't subtle for the most part.
Severe are your shot, stabbed, choked to unconsciousness, sexual assault. Those are generally the severe level.
And what we found with the child maltreatment cases for classified as severe, 66% on average were for severe neglect when we talk about severe cases with the physical violence, neglect, emotional violence. So we had over half were for severe neglect. I'm going to quickly introduce some language as we talk, because you're already talking about prevention. And what I've heard from work group leads and commanders is prevention is thrown around quite a bit and seems to mean different things to different people. So I wanted to get some really clear language on when we talk about prevention, what that is. Because I've heard, people enrolled in a program, that's preventative. Yes, it can be, but that's not the kind of prevention we're talking about. We're talking about primary prevention, which is primary prevention addresses the problem before they occur. That doesn't mean they're not having problems. For example, a family that's having financial distress, intervening while they have financial distress before it becomes domestic violence, suicide, or a homicide. So primary prevention, it's a systematic process that promotes a safe and healthy environment. And prevention, when we use prevention, tends to we're looking at the healthy outcomes. So reframe it so the desired healthy outcomes for instead of reducing domestic violence for prevention, we want to increase the healthy behaviors and the healthy aspects of the community. So there's a lot going on protective factors. I know we talk a lot about risk factors. There's a lot going on with protective factors, and we definitely need to focus on those and also build those. And when we talk about prevention, it is a research-based field. So I'm using general prevention, and we have the domestic violence prevention program manager here that can answer questions about domestic violence prevention with the prevention plan, their strategies. So general prevention is basically, this graph shows everybody has a responsibility for preventing domestic violence at the individual level, seeking self-care, getting help before it becomes a problem, promoting healthy family lifestyles, healthy individual lifestyles and skills, relationships, organizations at the command level, at the unit, making sure that, that there's not a tolerance for domestic violence or violence. And then at the community level, what are the community norms? What's the structure of the community? Policies and systems in place, and these include policies and systems that allow us to enforce our laws and regulations and possibly even discharge somebody when you talked about the felony or the severe cases or failure to rehab, when to draw the line on this person cannot be rehabilitated, when do they need to leave. So there are policies in place for that. And I'm not going to read these all. Again, when we look at the 6 primary prevention strategies, we're using all of these on the installation and what that looks like when we look at those domains that I just went over and the different. Not one should just be a standalone. That's not good science. A community should engage in all of the prevention strategies, information dissemination, prevention education, alternative activities when you're targeting a specific group, like those young parents that we were talking about, young couples. Problem identification and referral. We do really good with problem identification and referral. When we think about 30% of our family members that live on post, I've asked, and I follow it with Colonel Hibbard from 7th ID to ask FAP to pull out what is our percentage of cases. If our population is 30% live on post and our referrals are coming from 75% on post, that shows you our system is really working on post, and we'll get those numbers for you. We have a community-based process. The CHPC is a community-based process. All of the organization that I showed you, the organizational charts, and then environmental strategies. And then I did a snapshot. This is just a snapshot, putting together pretty quickly. There is a lot of things going on. But looking at the different domains I went over and addressing the 6 prevention strategies, here are some of the JBLM efforts that you were asking about that address prevention within those. So we have different skills support, life skills support, education, financial assistance programs. We have relationship counseling, relationship activities. We have, at the organizational level, emergent case management, required trainings. We have the the commander's first sergeant course. We have community things going on, law enforcement response. We talked about the response we saw when everyone stood up. And then the policies and systems in place. So again, this is just a snapshot what we have on Joint Base Lewis McChord. And so I just wanted to get us clear on prevention language as I turn this back over to Robin to talk about those changes and how FAP is getting at prevention. Go ahead, Robin.
Can I add one thing? Sir, one of the things that, this is Sergeant Major Mo Ryan, Joint Base. One of the synchronizing efforts is the emergent case management. Colonel Morgan is preparing to brief you. I know you got a one-on-one with him later on. But it's basically synchronizing a lot of the facilities, a lot of the resources that are both on the garrison side and the hospital side to help commanders as one issue comes up, this particular topic, we're talking about DV, but as that one comes up, we start looking across the field to see, well, was there another flag that come up, maybe in finances, or maybe in behavioral health, or maybe somewhere else, so we get a more comprehensive look at that particular soldier or that particular family. And through that emergent case management is where we get a better look at all of the resources that that particular soldier or family may need. And we'll be ready to talk to you about that, sir.
You're spot on. I look forward to the discussion. I just want to be clear on emergent case management. We came up with that for somebody who was at risk. Remember, somebody who was very at risk, a high risk, we would have a handoff of somebody who had knowledge of that particular soldier or airman to the rest of the organization. What I would like to get after is extrapolate what you've said even more, so that it's not even in the emergent case management, it's someone who has an issue and in another domain that now FAP finds out, so we can get that soldier and or airman to FAP earlier in the process, so that now we're truly getting ahead of the family issue to preclude domestic violence or child abuse, et cetera. So your issue of handing off information from one organization to another, and this gets after flattening the organization, sharing information. Perhaps I can get somebody to Robin earlier, which is what you're advocating, and that mitigates this becoming an issue and an offense. And perhaps either saves a family, saves a career, or saves somebody from getting hurt. But I look forward to this discussion, but that's kind of where we need to go on the installation, to get that person to you earlier. But I think it can only be done by how we share information and do the handoff of service members from one organization to another. So agree completely.
And Robin, if you can just take a few minutes and highlight some of the changes of the slides that are coming up.
If I may, just want to bring up the same thing from the SARB today. I took a note, and I took a note here. Who is responsible for collating all of the negative events in all of the various stovepipes and domains on the installation? Because you're going to come up with a number of X number of negative things happened on this installation over the course of the reporting period. The number of offenders or the perpetrators will be a Y. It will be less than that number. That's how you'll get to some of these more predictive analysis tools. If, this guy had a drinking event, he showed up on the bullseye chart twice. He's over in the ASAP, he's over this. And then the team leader. We haven't talked about team leaders and squad leaders yet. The most important master resiliency trainer of them all, the first line supervisor, we've kind of disempowered him with some of these big systems that will scare the heck out of a young buck sergeant. I'll just go do this or go do that, when it should be his or her responsibility. But if we can focus in and target the population that is finding its way onto every list, and he has kids, well, then you send him over to see this nice young lady over here, because he's already in 3 categories. We want to get him over here and get him some other help before we have to throw him out of the Army, because we've already invested a lot of money into him. So that's the tool, not this guy now has got all red bubbles on his MedPros, he must go to the dentist. Right. Anybody can do that. We want to know he needs to go and get these kinds of help before he fills out all the bubbles red. Not just the guy that's tripped enough now to get your attention.
Roger, sir.
Okay.
We talked about that in other meetings where it is Colonel Morgan, the command team here at the headquarters, and the directors who are providing the information, because we're the ones providing the services. So just to provide that snapshot, hey, this is what we know, providing that to the commands who are helping leaders get their soldiers through whatever issues. So we're the ones providing that information you're looking for, sir.
I think it would be helpful, because I know we got a lot of new people on board here, to explain what this emergent case management thing is. It's to help the commander at the lowest level connect the dots on all the stuff that's going on with a soldier at risk. So what we were having, again, was all these different stovepipes. And you didn't necessarily know all the information that, if you took the case, the example we used with the 2 NCOs here, all the people that stood up in the room had a little bit of information about these 2 soldiers, that if the chain of command had known all of that, they would have certainly done something. But the problem was they couldn't know, because all that information was held in these stovepipes. And emergent case management is designed for each of the stovepipes to immediately alert everyone else that, hey, there's something happening here that doesn't look good. So you got a soldier who gets a no pay due and he goes to ACS, or you got one that, hey, the same soldier, there's a blotter entry where the MPs had to go to his house because of an argument. And then there's another one that's, he's in ASAP for substance abuse issues. And how does the commander find out that the soldier, that's the same soldier in all 3 or 4 different cases? That's what we got to do here, is pull this all together so the knowledge is at the right level. And right now, we're getting better at it, but that's what we got to fix with this, I think, is what everybody's saying.
And sir, I'd like to add a little bit with the emergent case management piece with Ms. Grady not being here, in that there is a second part to the emergent case management, as the Command Sergeant Major was mentioning, is to respond to those high risk. There's another one where they meet regularly, and it's open for commanders that they have a referral, someone that doesn't necessarily pop up on a lot of triggers, someone, and they're calling those that are creeping up. So they may not hit all those red flags, but the commanders know something's going on. They have a sense that something is wrong. They can also convene the case management to review those cases on an ongoing basis. So there are other entry points for them for the emergent case management. And I'm going to turn this over to Robin. And Robin, we just have a few minutes if you want to highlight and then take any kind of questions that come up. And again, this is around changes that FAP is making.
Okay, so we're assisting with prevention. We're working with our cohort, Susan Domini. Thank you for being here. She's my other lead. When I call the installation and say, Susan, I need help, I don't have to ask twice. She's going to get me the information. She's going to come over, and we're going to storm through it and figure it out. We get it from ASAP and Jolie's people. We get it from the MPs and the MPI. This isn't just FAP, this is the team working the way we're supposed to work. We get it from medical, from our DOBH, embedded behavioral health, CAF bids. We're expanding services. We used to just do treatment groups, domestic violence mostly, a few parenting. Now we're doing individuals, couples, family therapy. You got it, you need it, we're doing it now. We increase services for service members who don't meet FAP. In other words, they didn't meet criteria for abuse. But what we were discovering is you come in and the command sits there and it didn't meet because maybe there was an act but the impact was marginal or the spouse denied. Then we close the case, and traditionally, guess what? 2 or 3 months later, they come back. So now we're saying to your young commanders, sir, will you agree with this treatment plan? We've developed the full treatment plan. Yes, he didn't meet criteria, she didn't meet criteria, but guess what? We're going to see him again, and they're nodding and saying, yes, I will support this. Can't get the civilian to come, but they can assist us in getting the service member into the building, and they do. And when the service member comes, and maybe he's being young and doesn't want to cooperate, we call and say, hey, sir, could you come over? They come and sit in the room with them, and like that, suddenly cooperation is flowing. We expanded services through the engagement of command. Every commander that comes in our office is greeted and dragged into an office where he is probably inundated with more than he wants. He leaves with business cards. We promise the moon. We promise potlucks, food, anything we can do to get him to come back. And they're coming back, or they're calling and saying, did you really mean that? Because I got this crazy case I need you to look at. It's working. New systems to ensure low severity allegations get treatment earlier. So we used to get a lot of cases and we'd screen them out. They didn't meet criteria. There wasn't an act and impact. Now we're saying, I don't care if it meets act and impact. You want to go to the next one? Because I think we stole this from the Navy. I admit it. I'm a Navy brat. We stole it. Fins fits the Navy. But these are family in need of services. These people are red flagging. They haven't reached the level of a FAP case yet, and guess what? We don't want them to. So what we're doing is we're immediately skipping the intake, the CRC, where they go before their committee to be decided, and we send them right to a treatment provider. These providers are really, really good at getting them to talk, getting them to open up. We do not, unless you've sent your soldier there, we're not going to contact command on a FINS case. But if they come in and they meet with us and we go, oh, Mother of God, this is way beyond offense, we're going to roll it into a FAP case, and you're going to be the first phone call we make to let you know that we got a bigger problem. It's working, and they're coming back because they're not mandated. Nobody's forcing them. They know they have a problem. We're revitalizing our child abuse and neglect treatment. Traditionally, we would do the child cases, but we didn't do treatment. A lot of them we sent out off post. We've decided that we have knowledge of this stuff, and we need to be providing the treatment. Most of us are former CPS workers before we got our MSWs and started doing therapy. We're walking our talk now. We're actually providing the treatment. We're looking at a couple different interactive therapies. Our colonel is assisting us in that. And we're also being a test site for a couple of DOD programs. Thank you, Susan. We have co-located the victim advocate and the new parent support. So we have a young couple come in and we determined that there's been some significant abuse. It used to be, I would say, sir, I'm sorry this happened to you. You need to get back in your automobile and drive over to wherever, and you can ask for a victim advocate. Now we take him by the hand and we walk him downstairs. He's not getting away, and we're handing him off to Susan's folks. And Susan made that happen for us, so I thank you for that. Also, new parent support. It's scary to have strangers come to your home, and you're worried they're going to judge you, like having your mother-in-law come who doesn't like you. So what we do now is we walk them down and we offer them books and hi, this is this nice lady. She wants to come visit with you. Before they leave, they have an appointment and they're engaged, and they're going to usually let us do it. And that's really important with the civilian spouses. Increased collaboration. Our law enforcement folks get, if we need a blotter, if we need a police report, if we need anything, we call the MPs, MPI, and CID, and they make it happen. But the way we figured out is if we're going to offer, or if we're going to ask for stuff, we got to give too, and not stonewall them, stovepipe them. So now we're working a lot closer. Command improvement, consultation, prevention. Susan's people come every week to case review committee, and the poor command doesn't get out of there without he gets the brochures and the cards of all the services her folks offer, and when can we schedule your next training? They don't know what hit them, but they get what they need.
Okay. And Robin, let me introduce the rest. We asked the FAP folks to come up to answer any questions, so we want to turn it over to Q&A. And Robin has been pointing to Susan Domini with the FAP on the prevention side with Armed Forces Community Service. And then we have Bob Steger from the Family Advocacy Program. He's a program specialist with Armed Forces Community Services. And they're here to definitely answer any questions. And I know we had lots of questions about prevention. How are we getting to the left of it, and how can we support commanders? So pending your questions.
Okay, I'll start, because I don't know the answer to this. But just like in one of our previous CHPCs, we talked about being able to more clearly define the medical retention decision point for the command to decide when is it time to just process this soldier out of the Army. Where and who would help a commander make that decision for domestic violence on retention decision point?
Okay, so traditionally a soldier comes to our building, they get assessed for a DV incident, and they get signed into treatment. So one of the caveats is they must complete treatment successfully. In other words, you can't come and be a stone. You have to actually participate and graduate and get your certificate. Traditionally, what we were doing is if they acted out, say, in that group, we would say treatment fail, and we would call the command and say treatment fail, and that is a criteria for separation. What we're doing now, sir, though, is we decided we needed to do more. So now when you come in and you start acting like a butthead, we're going to put you in individual counseling. We may be adding family counseling, marriage counseling. We're going to throw everything we have at you, and if we still can't get you where we need, we're going to make sure you're seeing your EBH provider at DOBH, maybe the CAFBIS provider, child and family assistance. We're going to make sure that we offer everything. The whole time this is going on, though, we're talking to you as the command. And seriously, sir, that comes down to command's decision. They have to make that final. But we're going to give you everything. Absolutely. But we're going to try everything before we say we're done, a treatment fail.
I have one question, please. All right, so you mentioned that the fins, and then you said we don't notify commands on if they don't really need, or if they don't meet whatever criteria, but they do need some services. So then I'm not understanding your understanding of what the emergent case management is supposed to be, because what I understood it was, if there is something, even if it's a small indicator, then there is a collective pool, a collective discussion that includes the commander, so that that commander can make an informed decision on how to coach, guide, lead, support that soldier and family through whatever issue. So if you're not notifying the commander, how are they going to know that there are more problems in this? Because it's the small things that pop up after the big thing. There's, oh yeah, here's the breadcrumb trail.
So let me go ahead and answer that one. So remember, at least half of the folks that are seen here are not active duty, are not service members, right? They're family members. They go through this as well. So although you have certainly the leadership right to see what goes on with your soldiers, you don't have that same right for the family members. So that confidentiality is pretty critical, at least from the medical side. So you're not going to get those that are not active duty for sure. For the other ones, these are voluntary, well,
Yes.
yeah, there's some criteria as well that you can see some of those as well for imminent danger and all the rest. But for the voluntary coming forward to get services, one of the things we've always done, and I think probably STDs are the ones people are most aware of, if you come forward and say, hey, I think I have a problem, we don't necessarily report that unless there's state requirements to report. So some of the confidentiality issues become a problem. So if there's evidence that there are danger, then we will call you, and we should call you. The rest of it, there's a negotiation that's going to happen anytime we're talking about these kinds of services. Because what we don't want to do is not have people come in because they're afraid we're going to tell everybody else, right? So we have to balance those two to make sure that we try to get it right. You're right, there's some information that you're probably not going to see, and that's why the dialogue back and forth is important. And when we have these kinds of indicators, we do the best we can to assess what information we have in terms of what might be valuable in order to share that. But you're right, it may not always be 100% of everything.
And sir, just adding on to that, we the social worker is going to do a suicide homicide assessment immediately. And the other thing that social worker on a FINS case on a volunteer walk-in is we're going to explain to them that we're mandated reporters for child, no hands, we're not playing. If a kid's getting hurt, it's reported. But the other piece is that we are going to ensure their safety and their spouse's safety. So if it reaches a certain level, even if we have an inkling that it does, you're on speed dial. We're not going to play with it. We're going to notify command, and it's going to roll over. And some of them get very angry with us, and that's okay. But we try to protect their privacy through HIPAA.
And do we have any more questions? I know that Susan Domini, there was a question that came up at the pre-brief about a prevention plan, and if the installation has a domestic violence prevention plan or set strategies.
Thank you, Trish. Yes, we have a 5-year strategic plan that we have put together with FAP Medical. With all of these changes, it probably needs to be updated to take a look at some of the things that are going on. We also develop an annual prevention plan, and our classes are pretty much scheduled way out in advance. However, as Trish mentioned earlier, whatever the issue is, we can be creative and respond in a fairly short period of time with whatever your specific need is for your unit. So we've got a lot of already canned programs. They're usually, the majority of them are evidence-based. We want to make sure that we're giving you a quality product that we know has results and will reduce actually the referrals to Robin's office eventually. And we want to make sure that that's getting out to you. But again, we can respond whatever your issues are. I would encourage you to meet with your FAP specialist. Each one of you have been assigned a FAP specialist. They try to get you within your first 90 days of taking command, but if you need a refresher, they're always willing to come back out, see what's going on in your unit, and see what we can do to help you get ahead and stop some of the violence that's going on.
Yes, please.
Just
go
for a
ahead.
second, my job is to train, and so every day or every other day I get requests from units to go out and train. And about 2 CHPCs ago, there was a question about how do we get to the left of this, and it was mentioned today too. One of the ways you get to the left of this is you train. And I know people, when they hear the word training, it really gets tough. I was in the Army for 30 years, I was a commander, I understand all that. But I can tell you that after each one of the trainings that I do, or one of the compatriots with me, we have people that come and approach us with clinical questions. And so many of us are licensed social workers, and they get the services before they become a statistic. So training is really, really important. The regulation says that every single unit, every single soldier is supposed to get training once a year. And I don't know if we can go to slide 55. Is that possible? I just want to show you something. I've had the opportunity to, oh, there you go. Back one. I'm sorry. No, 56 then. It says 55 on here. Keep going. There. That's it. That's the one. 53. This is what we do in annual training. And it's really, really important. We just don't talk about don't hit your wife or don't hit your kid. Okay? We try to engage the soldiers. Take a look at number 3, addressing single soldiers. It's a real priority to address single soldiers and talk to them about healthy relationships, to include all the things that you see up there. I got a great opportunity to address and talk with General Haley and his Command Sergeant Major, Colonel Gainey, and he did, about 2 weeks after I talked with Colonel Gainey, I addressed 750 soldiers in one of the theaters, and it was really engaging. The soldiers really accept this training. Again, it's not about just talking about hitting your wife or don't hit your kid. It's about relationships. And what we try to do is really tailor our presentations now to discuss exactly what you folks have been asking. And that's what's a healthy relationship. Because a lot of soldiers don't know. A lot of soldiers come from a situation where they were abused when they grew up. The Army actually has a higher population of those folks than the general civilian population. And so we do our best to really tailor trainings. We are here for you. And so please give us a phone call. Please make sure your annual training is done. But we will custom make any sort of presentation that you wish to address that so we can get to the left of this.
Okay.
Thank you.
Thank you, Bob. And I'll bring it back out to the group to see if there was any questions of our 3 FAP personnel here. All right, sir, with your permission, we'll move on to updates. So as we move forward and look at the future CHPCs and the health of the 4 states, I'm going to turn it over to Sheena Johnson, the Health Promotion Program Assistant, and she can talk to you about some of the events.
Good afternoon, everyone. And is this working? I did it earlier. I guess I have to use my computer too. A lot of technical difficulties today, apparently. There we go. Okay. Real quick, I'm going to go over the timeline here. Big things going on. Our upcoming Health of the Force events are all on here. I want to point out we have our 593rd Wellness Councils, 7th ID Commander Health of the Force Councils, which are our local councils, and we also have the HRAC and CHPCs. Our higher headquarters, ForceCom, they also have the R2 Council. In September will be the next one, so disregard the August one. Most likely they're going to be focusing on crime. And then also for the Fatality Review Board, we had a recent change. This slide says July 21st. It is actually July 20th, so please make a note of that as well. As for DA requirements, they are the double starred in red, and it was previously mentioned in the do-outs that we are working on our Health of the Force communication plan. And so please expect some feedback, or we will be expecting feedback, reaching out to our partners for that, as well as updating our strategic plan and working on our line of efforts for our working group action plans. So that is definitely collaboration with our partners through the HREC and our whole process that we've built. So definitely the CHPC process in the Health of the Force that we've built here at JBLM is making a great impact, not only here in the community, but through ForceCom and DA. So we are building the way. So thank you. And next, I think, is Colonel Holcomb. May I pass you the mic? And he's going to do a quick update on the LSRAT.
The bluff on the LSRAT is the Behavioral Health Process Action Team has been working very hard on it. We have got the final. We've got a milestone plan. The goal is to be able to have training products ready to roll out to the units of First Corps Choice, along with an op board come October. So we're currently putting together training packets for commanders and leaders, as well as our behavioral health professionals, in terms of how do we interact around the LSRAT. So I know we have some new folks in terms of if there are any questions about what the LSRAT is. It's a leader suicide risk assessment tool, looks at 7 domains and makes recommendations related to those domains that have been identified as significant risk factors in those soldiers who have actually completed suicide here on JBLM. So pending any questions.
Thank you. I know we're getting late in the day. I can just feel the energy drain. So I'll speak louder. Just wanted to, before we turn it over and go over some of the do-outs, some of the themes that I captured, we were talking about some communication issues, especially when it comes to confidentiality and having providers be able to communicate with commanders so they're informed about their soldiers, and making sure that we have those communication channels. Another theme is that deep dive that General Stammer had mentioned, that using the data to get to the left of the boom, what we need to do to target the right folks when it comes to prevention. As we think about that graph that showed that almost 70% of the domestic violence for spouse and intimate partner was coming from a very low-ranking and perhaps young and newly married, and hearing that, getting to the single soldiers, that's a way to use data to target a group. And the third is that retention point. When do we decide by either incident or how they behave in the program, how many incidents they have, or the length of time when we have to help a commander make that decision to whether to chapter or retain a soldier and get more resources. So those are some 3 big takeaways. And we have someone that is new to the CHPC today, our G1, First Corps G1, is Colonel McGregor. I'd like to welcome him. And he has been capturing some of the do-outs that we want to capture before we turn it over to closing remarks. Welcome, sir.
So I think you kind of covered some of these already, but we'll just we'll go over them just to make sure that everybody's captured these. So the first one is look at how well or how we can flatten the organization and achieve even more efficiency and expediency across results here at JBLM. Second one is how well are the MRTs actually affecting and impacting others as they should? And then what kind of effect, is it just an individual effect that they're having, or is that across the organization? What are some of the major causes of domestic violence here in our formations? I think we kind of touched on that a little bit, but just to kind of dig into that a little bit more. And then what are some of the precursors that we're seeing to where we can get ahead of that? One of the do-outs is to drill into the March 2016 stats and look at who those soldiers were, and then were any of those actually into FAP beforehand, and see if there's a connection there, if we can make a connection.
And Mike, on that one.
Yes, sir.
Not just were they, taking advantage of FAP services or, behavioral health counseling or something like that, but were there any other indicators that would have told the chain of command that there's an incident is about to happen if we don't intervene? And you might also add to that, given the last briefer, is had they attended any of that training or not? So the idea is, we're talking the hypothetical here. Logic would tell you that if you do these things, you will prevent the event from occurring. But just like we found out in sexual assault, sharp training doesn't fix the problem. Or suicides, resiliency training doesn't always fix the problem. In some cases it probably does, but it's really hard to zero in on what works and what doesn't, and it's going to be a little bit different for every person. So we got to make sure we understand what's causing this to happen, or we will never understand what we need to do to prevent it from happening.
Acknowledge, sir. And then the last one that I had was, who's responsible for collating all of the incidents across JBLM? Who takes all that information from the different stovepipes across the post and puts that, synthesizes all that information and then turns that into actual actionable items that we can work? So who's taking all that information, collating it, and making it actionable? And that is the last two out I had, sir.
Thank you. And as I mentioned before, this being an engagement forum is we have discussions here, and that's what's important, is that we have across the table discussions and have actionable items. So these discussions don't end at 16:30 today, that we will continue. And I'm going to turn the mic over for closing remarks to General Lanza.
Before we do that, any comments by any of the leaders in here, either military or civilian, General James or General Haley, or any of our directors from the organization on post? Sergeants Major?
Sir, I would just help with the last due-out, collating the data of information. That comes from the AFCS through Colonel Morgan, through us, to you. That's what we do, sir.
Okay. And that would be helpful in terms of how we show the data, which is Robin was very helpful in articulating what the data really means, so thanks. Just a couple of comments to close this out. First of all, to Robin, Susan, and Robert, thank you, but more importantly, thanking you for what you've done to say we're willing to take on more work to help commanders. That was not lost on me. I don't think it was lost on any commanders, that if we can get somebody to you early on in the process, you will take that on, and Colonel Place to put the resources towards that. Having a commander hear that is extremely important, Sergeants Major, so appreciate you bringing that up, and that is something that is extremely important. This whole discussion here of personal readiness is really what we're talking about. General James and I were at a meeting with the chief last week, and it was a 2-day meeting on readiness, We spent 3 hours just discussing personnel readiness. So all this discussion here, whether it's domestic violence, family issues, issues with soldiers and medical issues, this all deals with the readiness of our force. And whether you're enabling a family or enabling a soldier to be deployable, we are an Army that's going to be expeditionary in the future. In fact, we're moving in that direction. No longer will you have a year to rehab, which goes back to General Fuller's point here, where perhaps you had a year back at home station before the next deployment, and you had a chance to rehab and do a lot of different things. We've lost that luxury as an expeditionary force. So this dialogue between commanders, between organizations such as ACS and FAP and others is extremely important. And Mike, you're right, there is a balance of how much we can discuss, but when it comes to a suicide or someone who's at risk, there is no barrier to that. And just as Robin is shaking your head, yes, no, but that's good. There is no barrier to that to save someone's life. But what I do want to emphasize here is this discussion and the emphasis on personal readiness, which is going to drive the future of the Army to do our mission. And all these discussions that we're having, whether it be in the CHPC or whether it be in the SARB and others, deal with readiness. And that's how we should approach it. And we should look at mitigating the vulnerabilities that impact on the Army's ability to do our job, because at the end of the day, that's really why we're here. And all these organizations that we have here are enabling us to do our job and do our mission. Whether it's a family being able to support a deployment or being able to take care of itself when they're gone at home station is all part of building readiness in the formation. So again, this will be a critical issue for us in the future, or it certainly remains a critical issue for me, but more importantly, as the force gets smaller, how we enable ourselves with the personnel we do have is going to be extremely important. Keeping them fit to fight will be important. We're not going to get additional personnel. So those of you that have personnel that you're carrying for a long period of time, that are not deployable, that cannot rehab, those are the personnel that you're going to go fight with and or not take with you and be short. So how you work with our civilian leaders here to make that call on when a soldier is no longer available or needs to be moved on to something else to transition with dignity and respect is what the commanders need to be involved in. So, Robin, I appreciate you bringing that up because that is part of the dialogue we need to have with our civilian care professionals. So, again, this is the kind of dialogue I want to have in here. Trish and Sheena, thanks for bringing this up today, and I look forward to the next CHPC and appreciate all you're doing to continue to build readiness. Thanks very much. Courage, thanks.